PowerPoint that is under your course documents in Blackboard. Okay? So some people have it, everybody's going to get it, so we can follow along. It is a lot of words. It's not a lot of text, but there's a lot of words on the text. So we don't want you to have to scribble and take notes. And, you might have said this already, while we're talking, I'll do the first part, then I'll turn it over to Mr. Armstrong, because there is quite a bit of what to say. But while we're talking, we're also going to ask you questions. And the kinds of questions that we're going to ask you, you can think about this as we go through these diagnostic procedures, is what does the nurse need to know? And what the nurse needs to know would be what? What are the patients getting? Which is the indications for the test. Secondly, what other things might you want to know as a nurse?
What you're looking for? The reactions?
Right. So the indications, why are they getting it? What are you more, let me say it a different way, Jessica. But that's close. What is the nurse going to teach the patient about the test? What is the nurse going to teach the patient about prep for the test, right? Or monitor the patient as prep for the test? What is the nurse going to be involved in monitoring if that nurse is helping the physician with the test, such as they're an OR nurse and they're working with an arthroscopy, or they're an endoscopy nurse and they're working with a colonoscopy? And then what are you going to monitor the patient for post-procedure? Some things, there's really no, they just sort of leave and they're done. But some other things that might be more invasive, there might be something that you're monitoring that patient for, either in the post-procedure observation or PAC view, or when they get back up to the floor. And then, of course, part of that, post-procedure, what are you teaching them? Especially if they're going right home from the endo unit or the obs unit, right? Okay. So think about that while you see all these words, because it is a bit of a wordy presentation. But what you don't have on your outline view is the cool pictures. So I really invite you to look back at this PowerPoint when you're studying, not so much for test 3, but for test 4. Because test 3 is going to be competency 7, 8, 9. You did competency 7 and 8 already. Next week we'll do competency 9, which is on connective tissue diseases and joint replacement. And then we're going to start into oncology. Now, oncology patients get a lot of tests, but these tests aren't just for oncology patients, right? When Mr. Armstrong talks about arthroscopy, that might be related to a patient with a joint problem, which is what we'll talk about next week. Okay? All right. So always, you're not studying to be radiologists, but you need to know what they're doing in radiology. You may be working there, and you may be sending your patients there, but you need to know about these tests so you can teach your patients. Okay? All right. Everybody's in. So let's go ahead and maybe hit a light or two so that you guys can see up here. Is that too dark? No. Actually, they have some nice window. They have some nice window light. All right, so because you have this handout, which is the outline view, and on the back there's a little one-page patient education article about PET scans. Sort of the new kid on the block is positron emission testing. So many of you have had, how many of you had patients who went for a CT scan or a CAT scan? How many patients have had patients where you've had go for an MRI? Okay, but you may not have worked too much with the PET scans. Okay, so we'll talk about all of those. So you're going to be able, at the end of this, to explain what these tests are, why the patients are getting them, and what you're doing for prep, for intra-procedure, and for post-procedure, right? All right, a couple of terms, which will then come up during the rest of it. We all know that in Latin, you've got a prefix, a root, and a suffix. So if something's arteriography, you're actually studying or viewing the arteries. And in many cases, they'll use a radiopaque dye that will show up on X-ray. The next thing says barium. So barium swallows, barium enemas. Barium is a radiopaque compound that's used in röntgenography of the GI tract. So a barium swallow is going to look at what? The esophagus, the stomach, yeah. Sort of like an EGD would do with a scope, but it's just barium and then the barium enema looks from the bottom up. If somebody has an incomplete colonoscopy, for example, they can't get the scope all the way up, they'll send them for a barium enema. And they'll actually give this barium through an enema. The techs in radiology know how to do that. They know how to give enemas. And then the x-ray will show it. Oh, I just answered my question. Anyway, so what's the word röntgenography a fancy word for? X-ray. X-ray. Dr. Röntgen from Europe, long time ago, developed x-rays. Now, x-rays have certain limitations. Regular x-ray just looks mostly at what? What does it visualize? Bone, the skeleton, right? Which is why we have newer tests that look at other things like soft tissue. Bone densitometry. So it looks at bone density, right? A DEXA scan. We'll talk about that in a minute. So we want to know somebody's bone density to diagnose what? Osteoporosis, osteopenia, which is low bone density, or osteoporosis, where the density is so decreased it's actually considered the disease, osteoporosis, which puts that patient at risk for fractures. Exactly. A bronchoscopy. So an oscopy is a scope, usually a flexible lit scope, that's put into an orifice. In this case, the bronchoscopy is looking at the bronchi, the upper airway, larynx, trachea, and bronchi. A centesis pulls off what? Fluid. A paracentesis pulls off fluid from the peritoneum, the abdominal cavity in a patient who has what? Right, we'll study that. What about a thoracentesis? Where does that pull fluid from? The thorax. Specifically, between the visceral and parietal pleura, it's pulling off fluid from the pleural space, right? If somebody has a pleural effusion. What about an amniocentesis? Fluid is pulled from the amniotic fluid, right? And a pericardiocentesis? Between the myocardium and the pericardium, right? The fluid in the pericardial sac. Okay. When we say CT scan or CAT scan, CT means computerized tomography or computerized axial tomography. In a CT scan, the computer takes tomograms, which are slices of images through that organ that's being CT'd. Contrast medium, radiopaque substances for x-rays. Now, barium is one example. They can also give IV contrast mediums. When we talk briefly about IVPs, they're going to put an iodine-based contrast IV, follow it through the vascular system of the kidney and out through the rest of the urinary system. And an endoscopy uses an endoscope, usually to look at the, generally we're talking about the gastrointestinal system, but it's visualization of organs and cavities using an endoscope. And a lot of surgeries now are done less invasively than they used to be because they're done with an endoscopy procedure, like a laparoscope. A lap chole, for example. A lap chole. Your patient's just had a lap chole. You're taking care of them. What's a lap chole?
Gallbladder.
Tell me down here. What's a lap chole? Patient has a lap chole. So lap means what? Means laparoscopically. So that's the root, right? They took a laparoscope to go in and... Okay, now I'm going to say the whole word. Laparoscopic cholecystectomy. So now tell me what it is. What's a lap chole? Removal of the C-H-O-L-E. C-H-O-L-E. Laparoscopic cholecystectomy. What's an ectomy? Removal of. What's C-H-O-L-E? Your gallbladder. You've been right the whole time, but everybody else is looking at me like they never heard your gallbladder. A laparoscopic cholecystectomy is the use of a laparoscope to go in and pull out the gallbladder, isn't it? And so people can get that and go home the next day. Used to be a big abdominal incision. Now it's 4 punch holes. The laparoscope goes in, and ectomies the colon, removes the gallbladder. Right? Okay. So the endoscopy procedures. A lot of these gastroenterologists now have their own endoscopy suites, don't they? Like Greenbelt Endoscopy Center, where I go for my colonoscopies every 5 years, because they actually get all the money, but also because they do a lot of screening colonoscopies or EGDs through these endoscopic procedures. So what's an EGD? Right. What's it look at? The esophagus, the stomach, and the duodenum. It's an esophago-gastroduodenoscopy. Okay? An EGD is top down, a colonoscopy is bottom up with the endoscope. Okay, we have fiber optic scopes, we have rigid scopes. A lot of these oscopies now are done with fiber optic scopes with a light on the end. They can take samples, they can take biopsy specimens, washings, brushings, and they can see. Lumbar is the lower vertebrae in the back. Lumbar puncture. What are we pulling off and looking at in a lumbar puncture? Cerebrospinal fluid, right. And it's done in between two lumbar vertebrae, right? Okay. MRI. Everybody say it with me. MRI is an acronym for what? Magnetic resonance imaging. So what do we use to make the images? Powerful what? Magnets. Powerful magnets. Really nice pictures of soft tissue. It's not invasive, but what are some of the things patients complain about?
You're confined.
Confined, claustrophobia, right, and also can be loud. And what happens if there's some kind of metal on their body somewhere? What if they have a piercing in their labia or their nipple they didn't tell you about? It's going to rip it out because you can't have anything metal. There are a lot of things now that are put in people that aren't metal or that they're, non-magnetic metal like titanium. But some patients would have what? Like pacemakers, maybe an old portacath, clips from some kind of brain clipping, some kind of teeth stuff sometimes if they have a lot of magnetic metal. So they do have to be careful about that. We'll talk about that again in a minute. A mammogram is an x-ray of what? Your mammos, your breasts. Myelography. We don't do too many myelograms anymore because of MRIs, but they put the radiopaque material into the CSF and follow it. The paracentesis we've talked about, that's for ascites. The PET scan. The PET scan, you have a little article on the back. Imaging for scanning the body. PET scans actually use a glucose tracer, a metabolism of glucose. It's very interesting. All right. Scintillation is the emissions from radioactive substances. With thoracentesis we talked about. Removal of fluid from the pleural space. All right. I'm not going to get into a lot about IVPs because, unfortunately, we don't do them as much anymore because the MRIs take such good pictures. There is a slide towards the middle here where you'll see the same patient that shows you side by side a CT scan, a PET scan, and an MRI. Very interesting. It's not on your, if you printed it out yourself, you might have the picture. Okay, for an IVP, looks at what? The kidneys and the urinary tract. So normally you want to have normal kidneys and urinary tract, but it may show something like a stricture or a stone or a tumor. Okay. What they're going to do is they're going to put the iodine-based the iodine-based contrast, IV, and it's going to circulate through the vascular system of the kidneys and then out through the urine and show and then be x-rayed. So the problem with that is that because it's an iodine-based contrast, what do you have to make sure you ask the patient first?
Allergies.
Are they allergic to shellfish or iodine? Because if they are, they could have what? An allergic reaction. Patient's NPO the night before, a laxative or cathartic to clean out the bowel. Now, why are they cleaning out the bowel for an IVP? They're not looking at the bowel, are they? Why do you think they'd want to have the bowel cleaned out? What's it say on the second bullet? Client lies supine on the x-ray table. Flat pay to the abdomen is taken. That's like a KUV, kidneys, ureters, bladder, to ensure no residual stool can what? Interfere with visualization. You don't want the stool to be in the way of the picture. They can do a test dose of contrast medium to see if the patient has an allergic reaction. Always in these places where they're doing these radiology suites, they would have emergency treatment available if a patient has an allergic reaction. Sometimes patients will have a little nausea, a tiny bit of shortness of breath, or a hot flushed effect. You'll see that with the contrast they use for cardiac caths also, cardiac catheterizations, which is pictures of the coronary vessels. So Clint may actually have the hot flushed effect at the time of the IV push contrast. That's not an allergic reaction. And then they're going to take the pictures over 30 minutes to an hour. And post-op, you're going to monitor vital signs, urine output, etc. And then they go home. If they have an allergic reaction, what are some of the signs and symptoms of an allergic reaction, just in general?
Anaphylactic.
Itching. What are urticaria? Hives. And then if they get anaphylaxis, now what are you into?
Airway.
Airway and breathing. They can have laryngeal stridor, which means what's happening? Airway obstruction, right? And they can drop their blood pressure. They can go into shock, anaphylactic shock. It says here if the patient's allergic to food or drugs, they may also have an increased incidence of contact media allergy. And that's especially if it's iodine or shellfish. So what are you going to do? For an allergic reaction, of course, there are protocols, but you're going to do ABC. What's the medication we give for a severe allergic reaction? Benadryl and also epinephrine. EpiPens that people carry around. They carry around because epinephrine, which is adrenaline, is given for an allergic reaction to maintain airway patency. Along with Benadryl. What's the generic name for Benadryl? You know, guys, you're not going to have brand names anymore on any class. So you have to, when they say you're going to treat allergy with diphenhydramine, you have to know that that is Benadryl. Diphenhydramine. What kind of medication is diphenhydramine? What classification?
Antihistamine.
Antihistamine, right. It's an antihistamine. Good. You can buy it over the counter, right? Makes you sleepy, but it's a very good antihistamine. So what position do you want a patient in if they're having respiratory distress?
High
High
powers.
What do you want to put on them? Oxygen. O2, 6 liters. So they need to be sitting up with oxygen. You're going to give them meds as ordered. Epinephrine, Benadryl, maybe some corticosteroids. Slow, deep breaths, and antiemetics if they're vomiting. Okay. That's the treatment of an allergy. That could be for anything. The IVP, this just shows you a picture of a guy lying on an x-ray table, because it's actually an x-ray. This next one's kind of cool. This is an x-ray of the upper abdomen 10 minutes after injection of the contrast material, and it shows the kidneys, the collecting system, and the 2 ureters. A cool picture, right? Okay, here's another one 15 minutes later. Again, shows the urinary system. It's probably been 20 years or so now, but quick story. My ex-husband, who was a Navy officer, was treated at Bethesda Navy, at the time it was Bethesda Navy in Bethesda, for a UTI, which is uncommon in men. And they said, well, because it's uncommon in men, let's do an IVP. So he had an IVP in the radiology department and went home, and the resident read it as normal. About a month later, he got a call from the chairman of the urology department at Bethesda, the attending physician. He said, I always review all of the images from our department, urology, done over the past month, and I just have a slight index of suspicion that I think I might see something on your IVP. So we would like you to come back in for additional workup, which he did. Turns out he had a very small stage 1 renal cell carcinoma of the right kidney. They did a radical nephrectomy, and he's been fine ever since. So unfortunately, most people that have renal cell CA don't get it diagnosed small and early because there's generally no symptom and there's no screening for it. So a lot of times when we have people with renal cell carcinomas, it's stage 3 or stage 4 when they're diagnosed. And he was diagnosed so early that the treatment was the radical nephrectomy, and he's fine. So that's my little personal story. Okay. The next test is the what? The bone densitometry, which we call a DEXA scan. DEXA scan stands for, it's on your sheet, look at your sheet, dual X-ray, dual energy, X-ray absorptiometry, DXA or DEXA, dual energy X-ray absorptiometry. The cool thing about the DEXA is it's a very low amount of radiation. The X-ray source is below the patient. I've had a number of these because I have a family history. I fit a number of risk factors for osteoporosis, which you're going to tell me. I lay on the machine, flat on my back, knees bent, up on a box, and it scans above. The detector goes back and forth above me. The tech sits right next to me because it's very low and there's very low radiation and there's very little scatter. So she sits right next to me on her computer. All right, that's really all it says. So we want to look at bone density. We hope to have normal bone density, but we look at what we call standard deviation below normal, and that's based on the patient's age, race, gender. So who should have a DEXA scan, a screening DEXA scan? All women age 65 or older. Why? Because women are at higher risk of osteoporosis. Can men get it?
Yeah.
Sure. So after age 70, they need to be tested. If the patient's had a fragility, fracture, if they have a condition associated with low bone density. Can anybody think of any diseases that might have low bone density? Well, if they have parathyroid problems or thyroid problems, that could be. If they have calcium issues, sure. Sometimes people with renal failure. There's a cancer called multiple myeloma, plasma cell carcinoma of the bone marrow. Higher incidence in elderly African Americans, although other elderly people can get it too. Their bones become very demineralized and they're at high risk of pathologic fractures. You'll see a couple images of myeloma in a few minutes. Well, sickle cell disease could be, sure. It can cause a lot of things. It can cause decreased calcium and decreased circulation through the bone marrow. Yep. Rheumatoid arthritis, some of those autoimmune connective tissue diseases can affect the bone. All right. Medications associated with low bone density. What's the classification of meds? We give a lot. And it causes, over long-term use, it can cause osteoporosis. Steroids, corticosteroids. Now, your adrenal cortex normally makes and secretes your own endogenous glucocorticoids, right? But we also give exogenous glucocorticoids. We call them corticosteroids, and we give them to treat what? Inflammation, severe inflammation, really bad itises, right? Okay, so long-term use of steroids causes osteopenia or even osteoporosis. Good. And there's other meds too, but that's the one we use a lot. Anyone being treated for low bone density, anyone receiving therapy or medications for osteoporosis, you want to follow that. And there's some controversy these days about some of these medications used to treat osteoporosis. I have osteopenia, but I'm not real excited about the idea of taking any medications yet. So what do we teach somebody like me that has osteopenia to prevent it getting worse?
Increase calcium.
Vitamin D.
Calcium and vitamin D supplements, that's good. What else? Exercise. Yay, good old weight-bearing exercise, lifting weights. Okay, good. So my last DEXA was osteopenia, and my GYN nurse practitioner called me to tell me that and to talk about, because she's a nurse, I guess, but anyone should call and tell me what to do to prevent it from getting worse, right? Okay. No food or fluid restriction, no sedation. You basically are just going to lay on the flat X-ray table or scanning table. No jewelry or metal objects because you're going to be scanned. Previous fractures or bone scans might affect the results, so you should just tell them about it. Radiation sources below, detectors above. Don't worry too much about the T-scores and the Z-scores, but it does say these scores compare clients matched for age, sex, race, height, and weight. So I am over a certain age. My mother had osteoporosis, so I have family history. I have very small bones. I'm Caucasian. I have a lot of risk factors. So, but my score is still compared to others that I match with. And there's basically the drawing of the picture of the machine. All right. So we talked a little about MRIs. Basically, they're used to look for anything, and the abnormalities they can find is pretty much everything, which is what that slide says, huh? When you look at that, you want to, so you're hoping for normal, but it shows you anything because it shows you soft tissue. It can show the demyelinated plaques in the brain of someone with MS. It can show heart disease. It can show disc disease in the back. It can show all kinds of problems, soft tissue, blood flow, etc. So we're not going to read you all that because it's everything. Patient does need to give consent. So what's your responsibility for consent?
Witness.
You're witnessing the signature, right? You're not, the doctor has to explain why the patient's getting it and get their permission. You know, the risks, benefits, etc. Okay, so pacemaker, insulin pump, prostheses, metal implants, those are things like if they have metal in their body. Might be then contraindicated to do an MRI because of the magnets. They can do contrast or non-contrast. The contrast MRI uses things like, these like long words, glutamine. Anyway, that's what they're going to give if they're IV push to circulate, to take the picture if it's a contrast MRI. They can do them without. So what do you want to make sure that you teach the patient before they go into this closed tube? Basically pretty simple stuff. I had a friend who was a submarine officer in the Navy. Submarine officer. He was in these tubes for months at a time. He went for an MRI to see if he had a pituitary tumor. They slid him in. Nobody ever told him to keep his eyes closed. They never didn't give him a mask, didn't tell him anything. He opened his eyes halfway through, and it was right there. So he said, "You got to take me out." Nobody told him to keep his eyes closed. When I had my MRI in my brain, I kept my eyes closed. I was good. I did the desert island thing. They had some music piped in. You know, half an hour later, they pulled me out. They said, "Oh, now we're going to give you your IV contrast." Gave me the IV contrast, pushed me in again. But anyway, we want people to know to keep their eyes closed. We want them to know that they should wear a mask or keep their eyes closed because it prevents the claustrophobia. If somebody is too claustrophobic, we can either give them some Ativan. Anybody know the generic name for Ativan? Lorazepam. Good. Lorazepam. The PAMs are what kind of medications? Benzodiazepines. Valium, Librium, Xanax, Ativan. The PAMs are benzodiazepine tranquilizers. So if you give somebody enough Ativan, they'll be pretty relaxed in there, which is what they did for him the next time they took him in. Now, if he had Ativan, of course, he can't drive himself home. They did that with my mother, too. I had to drive her there, wait, and drive her home because they gave her Ativan because of her claustrophobia. Now, there are open MRIs. Open MRIs are for people that have too much claustrophobia, or what else? Or they're too big. You can't just go like this. Or they're too big. If we have somebody who's 500 pounds, they may not be able to fit into the standard closed MRI. Okay. And so here this talks about the claustrophobia, the sedation, and the not driving by themselves. Sick them off the road. But it's really important that the patient know to take out everything they can that's metal. And if they have something in their body that's metal, they need to tell somebody before they get in there. Because they're going to lie flat, still relax inside the tube magnet. Sometimes 20 to as long as 60 minutes. Patient voids before, so they don't have to pee in the middle of the test. That's the only reason for that. But metal. There's metal in a lot of things we don't even think about. One of the issues these days is the piercings. As I said, if somebody's got a piercing somewhere they don't want to tell you about, they'd better. They're going to find out in the middle of the test when it gets pulled out of them. Even some cosmetics have a little bit of metal fragments. And some of the new tattoos, some of the pretty reds and greens and blues, they're metal fragments. And that ink has metal in it. And so they can burn their arm or wherever it is on their body they have that tattoo. They need to tell somebody. It may not be able to get the MRI. Okay, so here's an MRI machine. This shows you the slices of the drawing of the brain. Here's the brain, starting at the top and going down. And this looks like a normal brain. But if they have some kind of space-occupying lesion, which could be what? What are some examples of space-occupying lesions in the brain? A tumor, a benign or malignant brain tumor, or a brain metastasis. Trauma, head trauma with, say, a bleed, maybe a subdural hematoma or some other kind of hemorrhage.
Like a knife to the head. You see those
Something
pictures?
in the brain, yeah. So a knife sticking into the head, that would be an example.
Like someone that has
Hydrocephalus, yeah, because the ventricles will enlarge as the CSF builds up. All those things that can cause increased intracranial pressure, good. A clot, a thrombotic stroke, right? That's a clot. Okay, there's a lot of examples of things that you could see on an MRI of the brain. Here's an MRI of the abdomen. Shows you the kidneys, shows you the liver, shows you the spleen, shows you the vertebral, the bones. Isn't that cool? Can show abnormalities. I mentioned to my group that if somebody has hypertension that's unresponsive to medications, there's a very rare cause of hypertension called a pheochromocytoma. It's a benign tumor of the adrenal medulla. And so they might see that tumor on an MR of the abdomen, take it out, and the pheo is gone, and the problem is fixed. Now, here's why no self-respecting orthopedic surgeon would ever do an arthroscopy or a knee replacement without a nice, pretty MR of their knee sitting up there next to the surgeon. Look how much great detail that shows. You got the femur, which is bone. You got the tibia, which is bone. But you also have the tendons, the meniscus. Somebody has a meniscal tear. They can go in and repair it, but they can see all that on this MRI. They can also do MRIs of the breast now. If somebody has a suspicious mammogram, they'll send them next maybe for an ultrasound, and then they could even do an MRI. But a mammogram is an X-ray. Okay. And they're looking to see normal or abnormalities in the breast. What are some examples of things you might see on a mammogram that they would send them for more testing?
A mass.
A mass, okay. Most breast masses are benign, but it's possible that it could be malignant. What's the only definitive diagnostic test for malignancy? A biopsy, a piece of that tissue of that mass. Good. But you can see a lot with these images. And this is an image of the breast. What about cysts? Are cysts cancer?
No, not all.
Cysts are fluid filled. They often look empty on mammograms. Some women have fibrocystic breasts. We're going to do a lab on breasts and breast cancer. But that's not breast cancer. That is hormonally mediated cystic breasts, right? Okay. So it's pictures, or I'm sorry, x-rays of the breast. So what do we teach a woman that's going for a mammogram, say tomorrow? What are we going to tell her when we call her up to remind her of her appointment? Right? Okay. Say that again.
Or lotion.
Right. Okay. Don't wear any of that stuff. Why?
False positive results.
You could smear the x-ray plate, cause abnormal, a bad picture. You know, it could affect the visualization of the breast. Okay. And then we tell her to wear pants, slacks, or a skirt rather than one whole dress. Why?
So they
You can
expose it
remove-
Because you're going to take everything off from the waist up. And it's nice if you still have your slacks on. But you take everything from the waist up off, put on the gown with the opening in the front. A lot of them, these places now have these cute little pink gowns. Can men get breast cancer? Yes. 1% or about 1,000 men a year. A couple semesters ago, we had 2 men at Anne Arundel oncology unit with breast cancer. One was an elderly African-American man. I think he was a retired principal. And another one was an elderly Caucasian man. And they had the same disease as women. But everything's pink. So that's, but they still had breast cancer. Uncommon, but possible. Okay, the next thing says review history. If the woman's had a breast implant, breast surgeries, breast reductions, abnormal mammograms. Now it might not be a regular screening mammogram. What level of prevention is a mammogram?
Secondary.
Secondary. I said screening. Yeah, secondary. You want to find it early. Mammogram doesn't keep you from getting breast cancer. Secondary prevention doesn't keep you from getting something. It finds it early. It's called early detection through screening. Okay. Minimal radiation exposure to the woman. Each breast one at a time, rest on the x-ray. Breast is compressed. So they say, lay it up there, and they help you, and then they bring the top down, and they say, hold your breath, click, and then it comes right back up. So the momentary discomfort is during the time that the breast is compressed. This is the patient to the left, the tech to the right. This is kind of the machine, the way the machine looks with the breast on it. So they'll do top down and then side to side, and they'll do both sides. Now it's mostly all digital, so you don't have to wait while they look at the films to see if they did it right. They can tell right there that they have everything they need, because they need to see all breast tissue, including the breast tissue that's under the arm, the tail of Spence. Okay, so what do we teach women about getting mammograms? Well, you mentioned what they should do the day of, but what if the woman says, I'm afraid to have a mammogram? What would you say?
That is the best tool for
Okay, well, you don't tell her it doesn't hurt. How do you know that? Did yours hurt? No, you don't say that. Never say it's not going to hurt. You're going to find out therapeutically what her concerns are, right? Some people say they don't want a mammogram because they're afraid it'll hurt. And really, the machines have gotten better, the techs have gotten better. I've never had any what I would call pain from a mammogram, but I know of some women, particularly very small-breasted women, who say that it has hurt at the time of the compression, because they have to compress it enough to get a picture. It's only for a couple seconds, and then they bring it back up. What if she says, I'm afraid to have a mammogram because I'm afraid I might have cancer? What?
Minimal radiation exposure.
Advantages of early detection.
I mean, that's irrational, but people say that, right? Does the mammogram give you cancer? No. What's the mammogram do? Find it early where your outcome is hopefully better. But people are afraid, aren't they? And then there's issues like access, cost, etc. But they do have these free mammavans and things that come around to some low-income areas and such. I know they come here to the campus sometimes. Okay. And that's basically a normal mammogram. Now, you do see some densities. Younger women have more dense breasts, makes it harder to find the abnormalities, which is why if they think they have something that they either can't see or something they do see, they'll send them for an ultrasound and an MRI. All right. Now, the nuclear medicine department here, we actually have a program. They take a lot of physics. They do a lot with radiation safety. They use radionuclides to take scanning pictures, nuclear medicine. They can scan the bone, they can scan the thyroid. There's a lot of things they can scan. They're going to give some kind of radionuclide, and then the patient lies under a scanning machine. In this case, it's detecting, a bone scan detects bone disease. What's osteomyelitis? What are they looking for? Infection of the bone, yeah. Sometimes we talk about diabetics. Sometimes they get these wounds on their foot. They have poor circulation. They have high blood glucose. The things get infected. The infection goes into the bone. That's called osteomyelitis. How do we treat it? Right, IV antibiotics if possible. And so they get a PICC line and they go home. And home care nurses can do IV antibiotics through a PICC line in the home or a rehab center, etc. Okay. Ankylosing spondylitis is one of the connective tissue diseases. A lot of times it's done to find bone mets. Carcinoma metastatic to the bone. What's a cancer you studied last semester that tends to spread to the bone? What cancer did you talk about in 1040? I think 1060 did a little bit. What cancer did you talk about last semester? We talked about prostate cancer, didn't you? You talked about male reproductive, and you talked about prostate cancer. Prostate cancer is higher incidence in elderly men. Actually, elderly black men have an even higher incidence, and it tends to spread from the prostate to the bone. Those are called bone mets. Other cancers, like breast cancer, etc., can also metastasize to the bone. So a bone scan can see, is there bony metastasis? And then see if the treatment, radiation therapy, chemotherapy, etc., is helping to shrink that bone met or not. It's used to determine unexplained bone pain, find out what's wrong. Look for abnormal healing of fractures or degenerative bone disorders, maybe rheumatoid arthritis that's causing destruction of bone. Okay. That's what this says here. Explain the process. Usually it's for metastatic cancer, but don't assume that. Find out why that patient's getting it. They don't do scans, nuclear medicine scans on pregnant women. Why? Because we don't want to expose the fetus to the nuclear injection, the radionuclide, technetium-99 or some other kind of radionuclide. About 3 hours before, then we force fluids. Why do we tell them to drink a lot of fluid but after they get the IV radionuclide?
You want to clear the house.
You want to circulate it. Well, that's before. Before, you want them to get it through the bone. Afterwards, you want them to flush it out of the body. So they're going to be supine under the camera, live for 20 minutes, reposition prone and lateral to get pictures of their back and their hips. And then afterwards, after a scan, patients just go home. There's no post-treatment. But the fluids are forced after the scan, as you said, to flush it out of the body. All right, PET scans, positron emission tomography. So tomograms are slices they take through the body. It studies a lot of things. It really does light up tumors, primary and metastatic tumors. So they use it a lot in oncology, but you can also use it for coronary artery disease, cerebrovascular accidents, lung nodules, colorectal metastasis, etc. It says differentiates between benign and malignant tumors. They can look at the characteristic of the tumor. They can't be sure until the pathologist looks at the biopsy specimen under the microscope. That's why medical doctors called pathologists make a lot of money, because they're responsible for determining if this patient has a benign, non-cancerous mass or cancer or malignant tumor. Okay, so my sister actually was sent for a PET scanner. These are not as widely available. I remember when the MRIs weren't that widely available. I had somebody who had to go to the Bethesda Navy at 2:10 a.m. for his outpatient MRI, because that's when they had time. But now the PET scans aren't that widely available. They're very expensive. My sister's doctor sent her for a PET scan because she was having unexplained night fevers, and they wanted to see if she had lymphoma, because one of the symptoms of lymphoma, Hodgkin's or non-Hodgkin's, is night fevers and night sweats. She didn't have lymphoma. Her insurance company refused to pay for the PET scan because they said the doctor should have done other cheaper tests first, and it was, I think, $2,600. Probably it was hormonal or menopause, I don't know, but it wasn't lymphoma. So they did scan her whole body. You can look at seizure activity or brain regions. They do put an IV in, sometimes an arterial line, but definitely an IV. The IV is for the injection of the radioisotope. Patient needs consent. Make sure the patient's not pregnant. Claustrophobia. Head inside the scanner for 45 minutes. It says here on your slides, if you all have this, pre-medicate with non-aspirin analgesia if the client has some pain. So what's that? What's the most common non-aspirin analgesic that we give people? What's an analgesic?
Pain
Pain med, right? Okay, there's lots of different categories or classifications of analgesics. Now we could give them opiates, but that's not what they're asking. This is for mild pain. What's the non-aspirin analgesic? Tylenol. Acetaminophen. We don't want to give aspirin or NSAIDs because it can affect the metabolism of glucose and the results. No sedatives are given because they alter metabolism. Avoid caffeine, alcohol, and nicotine 24 hours before the test because that can affect metabolism. There are NCO prior to study, so they need to know that. If they're diabetic, they have to have their blood sugar managed. Okay, they're going to lie there for an hour or two. Vital signs are taken, and post-scan lines are discontinued, and there's normal activity and diet. This is the picture of the equipment. Looks a lot like an MRI or a CT scan. Now, here's the cool pictures I was talking about, which you don't have if you just have the outline handout. This is a patient with lymphoma. Lymphoma is what? Cancer of the lymph system, right? Now, this patient has metastatic lymphoma. It's in a number of areas throughout the body. I don't know what lymph node it started in, but it's now showing up on this PET scan as the black areas. Looks like lymph nodes maybe in the neck or even the base of the brain, some mediastinal nodes. I see the spleen lit up really dark. Remember, the spleen is where a lot of these things are sequestered, a lot of the red cells, they can get splenomegaly. Something down, looks like it's even down maybe in the bladder or the rectal area. Again, we're not radiologists. Okay, here's what I was talking about. This is a PET scan of a patient with multiple myeloma, plasma cell carcinoma of the bone marrow. So lymphomas, leukemias, myelomas, you can't really all find necessarily one solid tumor to measure, like you would in a breast or a colon or whatever, because it's throughout the bone marrow. And you can see, this is a typical myeloma PET scan, that it is through all the bones, even the skull, the vertebral column, I see shoulders, I see ribs, and an incredible picture of the pelvis, and the bone marrow in the pelvis with these plasma cell carcinomas. Okay, so that would be good for diagnosis along with a bone marrow biopsy. Here's another non-Hodgkin's lymphoma. Lymphomas, Hodgkin's or non-Hodgkin's, but it's still all lymphoma. Shows you the areas with the arrows where they're finding the cancer. Here's the coolest picture. This is, it says PET scan, but what it actually has is, this says CT, so it's a side view and a front to back. This says PET scan, the side view and the front to back, same patient. And here is the MRI, the side view and the front to back. What's melanoma? Don't confuse melanoma
skin
with myeloma.
cancer.
Yeah.
Skin cancer.
Melanoma, the funny-looking mole, the pigmented nevus that becomes malignant and then can become metastatic and lethal. It's a pretty aggressive cancer. Can dark-skinned people get melanoma? Yes. And so it's really important for all communities to understand that if they have moles, the moles should be checked by a dermatologist, that you don't put your kids out in the sun without sunblock, and that your moles should be checked. And if you have something suspicious, the mole changes symmetry, border, color, diameter, it needs to be biopsied. Okay, so this is a patient with malignant melanoma. You can see, really the best test to see the metastases is which one? The PET scan. Because everything else fades to the background and this just lights up black. You can kind of see it when you look at the MRI. It's kind of pink and green. You can see the area a lot up in the skull. They have brain mets. You can see some stuff in what looks like might even be the heart. Something down in what may be the bladder. So you can see a lot on the MRI, but the PET scan really lights up the cancer. So it's a good diagnostic and following test for oncology. Mr. Armstrong, you're on. Ken works with a lot of OR procedures, in and out surgical procedures like all of these oscopies and oscopies.
Right. So, oscopy, of course, as she was talking about the word a while ago, is that it's all about visualization. So, arthro, which is the first premise of this, is dealing with orthopedics. So, an arthroscopy can be any endoscopic examination.
Any joint.
Any joint, right. Can be a endoscopic examination of any joint. Shoulder, elbow, knee, hip. Usually it's more often the shoulders or the knees. So what we're doing is that for any procedure, standard stuff. We're going to get the procedure signed, okay? Normally, if there is not going to be general anesthetic provided, sometimes you don't have to have food or fluid restrictions. But if there's going to be any type of sedation given, where it's going to be monitored by the nurse, or a general anesthetic given, of course, then, there's that time frame where they do not need to be eating or drinking. Standard things, the reason why I'm going to go over this now is because you're going to see that repeating itself in several of the other slides. So I'm going to say standard preoperative procedure, and that's what I'm going to go over now, will apply. And that's kind of cut down a little time saying the same thing over, okay? NPO is very common after midnight for general or spinal anesthesia or something that is a sedative type of thing, okay? Normally, if the patient happens to have a lot of hair in the area, we're going to shave that because that has a lot of germs in it, and we figured out that clipping the hair, okay, helps kind of reduce some of that bowel burden in the area, okay? So, basically what we're going to be doing is, as an example, if we're doing a knee, we're going to place the knee in a knee holder after the patient's been anesthetized. We're going to make 3 little incisions. Let's see what's on this one. A lot of words. 3 different incisions, okay? How we make this where it's not a lot of blood is we'll put a tourniquet on the extremity if it's a knee, and we'll basically kind of run that up to a level that doesn't, completely starve the leg, but it really kind of reduces the amount of blood flow to the leg. And then what we'll do is that we'll place a camera in through one hole that has a light source. We'll place another component in, which is moving fluid through the joint, keeps the joint expanded so that we can see what's going on, okay? And then if we need to have some kind of operative instrument, smoothing down a surface, or going in and retrieving something like graspers or something, then we have that third port that we can be able to do this with, okay? So, tourniquet, instill the solution in the knee, the knee's placed 45 degrees, small incisions, procedure's completed, the joint is drained, the incisions are basically kind of sutured up, and then, or we can do butterflies on the outside, just kind of depends. And then what we'll probably do is that we'll wrap that with an ACE because there'll be some swelling in that area, plus you don't always get all the fluid out of it. So the ACE kind of adds a little bit of compression to it, okay? Anytime that you're dealing with somebody who's getting a procedure on an extremity, okay, you need to make certain that you can account for all of the different neurovascular checks that are associated with an extremity, okay? So very quickly we'll run through those, right? Okay, so we need to check to make sure, cardiac-wise, that there's what? A pulse, right? So we check for a pulse. We would also check for warmth, correct? Okay, so we check for the pulse, we check for warmth, we check for sensation. Can you feel? Okay. Can you move it yourself? Can you point your toes? Can you move your hands? Okay. So basically we'll be doing those neuro assessments for just a brief period of time afterwards, just to make sure that everything is returning, okay, and that the patient doesn't notice any major problems. Anytime that you do one of these arthroscopies and you're in there in that joint, all those nerves that run through the leg, it's always a possibility that it could be a complication where one of those nerves could actually be clipped or hit or damaged. So that's one of the other reasons, okay? Monitor vital signs, necessary, especially after general procedures. Observe for any kind of complications, edema, swelling, excessive drainage. If you have, as an example, excessive swelling in a knee, and you don't account for that or intervene, then everything down below that can lose the blood flow. And so that's why you're checking the pulse in the foot, even though the knee is what's been operated on, right? And to make sure the foot is warm, because you're wanting to make sure that that flow is moving back and forth, okay?
So, Mr. Armstrong,
Yes, ma'am.
This is for like ACL repairs, MCL repairs, like things like that? Is that what they would do this for? Okay.
Or just a plain old arthroscopy. They go in and say that they're having problems with their knee, and they go in and they clean the cartilage up.
Okay.
Trying to buy them a little bit more time before they have to have that joint replacement done. Okay. So clicking, knee hanging, just generally having pain upon ambulation, they'll do those kind of procedures. Okay. So they'll stay off that knee, probably with crutches for a day. Keep the knee elevated whenever that they're home. Okay. Apply ice packs, physician's order. Observe for complications. This is the key thing. Okay. So we're looking for localized and systemic symptoms. Fever, systemic, redness around the site, local, drainage, local, alteration in color of drainage, okay, increased edema, pain, okay, those are the big things we want to be taking a look at around the site, right, okay, but if the patient starts talking about a fever, then we have a systemic problem, okay.
What's the ice do?
Pardon me?
Why do we tell, not messing up, why do we tell the patient to use ice?
It's a
Vasoconstriction.
Do what?
Vasoconstriction.
Inflammation.
And pain.
No, it's not for the pain. What does ice
Inflammation.
For the blood.
do? Inflammation. Well, particularly it decreases what?
Blood.
Swelling.
Swelling.
Swelling. The ice is for the swelling, which is, some of that is normal after the procedure. We're going to have some swelling. It's for the swelling.
Remind the patient to make their post-op physician appointment and do everything that's necessary according to orders, okay? All of this kind of stuff is all printed up and it's given to the patient in the discharge information. Tells them all signs and symptoms that are going to happen, ones that are unexpected, and depending upon how involved they get as to, do they just call the doctor or do they need to go to an emergency room? Okay, and it also will outline if there's any antibiotic therapy that's going to follow afterwards, just to make sure. Then that'll have some description there talking about how to take that medication appropriately. Bronchoscopy is the same thing, but we're looking in a different place. Okay, instead of looking in a joint, now we're going to be looking in the main stem of the lung, the bronchus, okay, and then we can look in different areas of the lung depending upon how far into the lung fields we wish to go. So it's a direct inspection starting with the voice box, which is the larynx, through the trachea, bronchi, standard metal bronchoscopy scope or flexible bronchoscope called a bronchofibroscope, but we don't see an awful lot of the rigid ones anymore, okay? Has a lot of problems. If you're placing something that rigid down someone's throat, you can very easily break their teeth. So you don't see them used that much except in an OR. But the flexible scopes are much easier to use. Okay. You can also use them as diagnostic bronchoscopies, and that means that you can put snares down them to get pieces of tissue. You can do biopsy forceps. You can do things through those scopes nowadays. They're very sophisticated, okay? Main purpose is that visualization and specimen collection, okay? So we'll bring patients in who maybe have a long chronic cough. They either have a history of smoking or have worked somewhere, say in a manufacturing area or something, and they think that they may have some cancer, okay, that we need to get a direct visualization and some tissue sample for. Okay, standard preoperative procedure begins the first of this. Consent, history, NPO. These patients are normally going to be a general anesthetic kind of patients, okay? Because you need for that airway not to be reacting when you're doing the scope, okay? Since you're going to be in their airway. So these are usually general types of procedures. Dentures, contact lenses, jury, standard things need to come out and not be in the way. Vital signs and records. There are some different types of medications that can be given preoperatively.
What's atropine do, guys?
Decrease
Decrease secretions. Very good.
Kind of dries you out a little bit,
So
doesn't
that's
it?
why you would use it pre-op. Yeah.
Dries you out.
Give me one.
Okay. Depending upon what they're wanting to do with the bronchoscopy, okay, a lot of times, majority, I've never seen too many of them in a sitting position. It's always been in a supine position, okay, with the head back, because you're looking for the tube to kind of go in more of a direct way. Like I said, usually the patient is anesthetized or have general anesthetic, so they usually don't spray anything in the back of the throat normally, okay? Normally you haven't got to be too worried about them waking up.
I saw a patient
Throwing
at
up.
Arundel Oncology where the guy did it at the bedside. And the patient had conscious sedation and he sprayed the back of the throat.
Yeah, I haven't been on the
It was-
floor
it
to
was a
see them
bedside
having
bronch.
done. One of the reasons that we did not mention at the beginning of this class, while we're going through this, is because so many of these things are moving to the bedside. And you as the nurse are going to be responsible for seeing and understanding this. And when the doctor walks in and says, okay, we're ready, and you go, well, yeah, we're ready. Well,
Where's the equipment?
yeah, where's the equipment?
What's
Where's
the
the
patient
consent
status?
forms? The patient know what's going on? Do you have all the medications? Do you have the emergency equipment in case we get into problems instead of, oh, okay, yeah, I'm good. Well, okay, so this is kind of why we're doing some of this, okay? But I have not personally seen one at the bedside. I've seen not a colonoscopy. Well, I have seen a colonoscopy at the bedside, but I've also seen the gastroscopy at the bedside, where they put the tube all the way down, which we'll talk about in a second,
Yeah.
into the stomach.
Percutaneous
Yeah,
anesthetic
but not.
gastroscopy.
I haven't seen too many though of the bronchoscopies at the bedside.
But it was
Yeah.
at Arundel.
So it just kind of depends. So we're collecting specimens again. We're visualizing, collecting specimens. Like I said, I guess at the bedside, did they go through the patient's nose?
Yeah, they did.
They did? Okay. Okay. Majority of the time, if they're in the OR, they go through the mouth. Okay, because we can control all of this. We have a special device, a special gag, pardon me, that we can use in order to be able to get in there to the procedure, keep the patient's mouth open, monitor the vital signs. Afterwards, the patient may have some bloody sputum because of removing that tissue, okay? And actually, just making the approach with that scope, we can also have some tissue also
Little trauma.
roughed up there a little bit. Yes, ma'am.
How do they keep a patent airway if you're going into the bronchi, though? Like, how do they keep that?
Around the scope.
They go,
Mhm.
okay.
They'll put in, yeah, what they'll do is that they will put in a special tube that has a side piece on it.
Okay.
And so it'll keep the pressure going, and of course the bronchoscopy scope is much smaller than the breathing tube.
Yeah, it's almost like an endotracheal tube attached to the outside. So they have an airway. And
Right.
then they can put in a bite block, like you said, to keep the airway open in the mouth.
Oh yeah, they put all that kind of good stuff in there. So it's a lot easier to manage the patients when they're completely anesthetized with one of these than trying to manage them with that conscious sedation. Okay, because you're walking a very thin line with them breathing on their own and then suddenly them not, and you intervening suddenly at a bedside for a patient who's gone just a little bit too far into the conscious sedation part, you know. And of course, back to this, monitor for bloody sputum afterwards. Patient cannot eat or drink post-operatively until, what does this say?
Gag
reflex.
What does the gag reflex do? Why is that important to us? It protects our airway, right? It protects our airway. So until that gag reflex returns, the patient gets nothing by mouth. You don't get anything else today. Until the gag reflex returns, you don't give anybody anything by mouth. If you ever suspect that a patient cannot protect their own airway, you do not put anything in their mouth, right?
What happens if you give somebody a glass of water and their gag reflex hasn't returned?
Aspirin.
It's going in their lungs.
Aspiration. That's right. Exactly. So we've talked about some of the stuff in the joint. We've talked about taking a look in their lungs. Now we can look in their digestive tract, right? This is from the bottom up. Okay, colonoscopy is basically taking a look at the colon. You can look all the way through the large colon and all the way over to where it attaches to the small colon, to the small intestines, because that is an area that has a high percentage of cancers noted in that area. So you have to go all the way up and all the way over. So some of those things are this long, from my hand all the way to the floor. And they just kind of keep right on pushing it right on in there. Okay? And these patients, a lot of these patients have conscious sedation. Okay? So they're not aware of what's going on, but they're still able to breathe. We don't need to put a breathing tube in for this. Okay? Standard operating procedures for preoperative types of things. Okay? Clear liquid diet for 12 to 24 hours on some of these, because we're wanting to, now we're in the digestive tract, we need a clear view. So now we need to wash out all the stuff that's in the digestive tract so that we can visualize the sides of the walls and everything in there, okay? So we're going to give them clear liquid diet for 12 to 24 hours, NPO for 6 to 8 hours for the procedure. There's a bowel cleansing routine that you can give patients that they hate.
There's a couple different kinds.
There's a whole lot of...
I've had to read colonoscopies. The worst part is the bowel prep.
The worst part is the bowel prep.
If you've ever had a bowel prep, that's the worst part. Colonoscopy is a piece of cake.
Yeah.
But you don't remember. But the bowel prep, you have to be completely cleaned out, and your patients have to be completely cleaned out.
Correct.
Or what happens? They send them back.
That's right, and then we have to start this thing all over again.
Excuse me, Miss Ames. Is there a student in here by the name of Solange? Do you have a student by the name of Solange?
No.
Solange.
Solange.
No, not in here.
Sorry, not in this 2020 section. Is it a 2020 student?
I don't know. I have no idea.
Okay. It's showing
Yeah.
up here.
So the bowel prep is going to be the big problem. Okay. They can use a couple of different ways to do this. They can use something called Go Lightly, which is a complete lie. Go Lightly. You can use Docalax to be able to do this. You can also use what they call magnesium citrate. You can use anything that is kind of is in the cathartic family. Okay. A lot of times it's that standard Go Lightly that they have nowadays for these types of procedures.
They have flavors for it, but it's still nasty.
It's-
It still tastes. What's it taste like, guys? It tastes like it's hypertonic because it is.
So
It's
it has a
osmotic
lot of
cathartic.
salt
salt,
because
it's
it's
very
drawing water,
Water. It's
right?
osmotic cathartic.
Right.
Pulls
So
water into the bowel.
we're going to instruct the patient if they have to take any medications or things, when drinking that Go Lightly, okay, will not be digested. So there's no need in them taking their medications because it's not going to stay in long enough to do any good. Okay. Medications that interfere with coagulation, aspirin, NSAIDs, iron medications, alcohol, they have to be avoided for a period of time before, probably about a week. Okay. So baseline assessments every 15 minutes during the procedure, peripheral access in case of an emergency.
And also to give the meds.
We give the meds also.
The nurse, the RN, will start the IV as soon as you come in as they're getting ready to go back.
A lot of times they'll have a CNRA at the bedside, giving the sedation, okay?
Yeah,
There's an
usually
anesthesiologist available in case we happen to need some extended care there, okay? So, left side, okay? So, when you're dealing with colonoscopy, it's talking about the left side there, right? Legs drawn up, okay? We are going to be going from the rectum through the descending colon, across the transverse, and down the ascending, okay? All the way over.
And they pump you full of air.
Yep, that's
They
what
can
kind
see.
of dilates the valve so that they can see the wall and take a look at it and they can visualize with the light, okay? So, they use several different things nowadays. For the conscious sedation, a lot of times they just use a mixture of propofol, okay? And then mix it with normal saline, and they just administer that slowly in a very controlled environment, which is the way it's supposed to be given, okay?
Not in your bedroom.
Not in your bedroom. No.
Where did we learn about propofol? You guys that are laughing know what I meant.
Michael
Michael
Jackson.
Jackson, that's exactly what
Michael
killed him.
Jackson juice. That was what killed him.
So, we're going to, like I said, make the patient where they're unaware. We're going to go in. We can do all different kinds of testing on some of this stuff because we're doing biopsies, things like that. Okay, so what we're going to do then is that after we're done, we will take the patient back over to recovery once they've got their gag reflex back, and we know they're drinking and things like that, and they've expelled all that air out, which is another problem because they have to, or that air will make you nauseated, definitely. So you have to expel the air out. The patient can return to a normal diet and fluids after they are doing fine, and then they're sent home just to report certain things like rectal bleeding, abdominal pain, distension, any kind of purulent rectal drainage which may indicate any kind of an infection or anything.
The abdominal pain. If they have a rigid, hard abdomen, what might have happened as a complication of this test?
Peritonitis.
Peritonitis because what
But
happened?
how?
Preparation.
Yeah, you can
Perforation, thank
push
you.
that long hose.
That's the word.
Yeah.
Perforation. And sometimes they've got these 90-year-old people, and
Oh,
they're doing
yeah.
screening colonoscopies. They're at very high risk of
Yeah.
perforation. If they perforate, they got to take them immediately to the hospital, go to the OR, and sew the hole closed. So from the Greenbelt endoscopy suite, I saw a patient come to the ED at doctor's and up to the OR because they had perforated her in her colonoscopy. They knew they did it, so they took her right away. That was good because at least they knew it had happened. Sometimes if it's a small perforation, it may take a couple days while they're getting peritonitis to figure it out. That's the worst case scenario.
That is the worst case scenario. Exactly. Now we can go to the other end. Esophagoduodenoscopy. So esophagus, gastro's the stomach, and then the duodenum is the duodenal part, okay? So that is the connection between the stomach going into the small intestine, okay? So we have a scope that can go that long distance also, okay? And again, kind of the standard stuff, your visualization and endoscopy of the stomach and the duodenum can be used therapeutically for cartery, scleroting agents, bleeding varices, stomach ulcers, things like that. So what if we already talked a little bit about that may have bleeding varices associated with their esophagus?
Fever.
Liver,
Huh?
the liver backs up.
Okay, so people who are in,
Portal
yes, that's right,
hypertension.
who due to liver failure, a lot of times can be the chronic alcoholics, will develop these esophageal varices, okay? And a lot of times they are vomiting up bright red blood because it is close up here to the top, right? So we can go in, and this would be the procedure that we would need to do to see what we were up against, okay? Now, I have seen this done at the bedside in an ICU with somebody barfing blood up from their toenails like, okay? And so, sometimes you don't have the luxury of NPO 6 to 8 hours. You just kind of got to roll with this. But people who are just coming in for an EGD, elective procedure, okay? Conscious sedation, that's what we did at the bedside for that patient. And like I said, we can go in, take biopsies, see if we need to do some sclerotting agent. Means that we would spray something on there that would make that surface draw and get sclerotic and hard, right? So that would be a protection from it breaking, right? Breaking open, right? So it'd be basically like doing a cautery procedure on it, okay? So after the test, 30 minutes for the assessment, NPO into the gag reflex returns. You're going to be running this tube down. They're going to have a sore throat, okay? Throat discomfort for a day or two. And the last one is a tiny bit different. It's similar but a little different from the standpoint of what we're doing with this one is the fact that patient can have gallstones, okay? That's what's driving them having needing to have a cholecystectomy, which is what we talked about a while ago. But that's just removal of the gallbladder. What happens if a stone slips out of the gallbladder and lodges itself in that duct that connects the gallbladder, the liver, and the intestinal tract? When that happens, the entrance into the intestinal tract is blocked. So we go down with a special scope that has the ability for us to be able to visualize, okay, and be able to take a look at this special duct. Even the pancreas has a connection in there in that area, okay? So what we would do is that they go in and they cut that little entrance open, and then they retrograde, which means they go back up into this thing. And that's why it's called a retrograde cholangiopancreatography, okay? Endoscopic retrograde cholangiopancreatography. We have to be prepared to do one of these anytime that we do a cholecystectomy on somebody. We may need to do a cholangiogram in the OR while they're on the operating table, okay? And so this is a little different. This is when they just go into an outpatient procedure where they're still having abdominal pain after they've had their gallbladder procedure, okay? And so NPO, okay, they can do the conscious sedation on them. Other people, they're going to be, you know, completely out if they're having the cholecystectomy. And then, like I said, monitoring the vital signs. Hopefully we can pull those stones out and clear out that special bile duct, okay?
I was going to mention the scope, because you talked about the scope. Has anybody been following the news regarding this scope?
About any of these scopes,
well,
really?
Yeah, but it was the ERCP scope that caused what? Big national news.
Was it an infection of?
Yeah. The superbug. There's a 19-year-old kid in Cedar Sinai in Los Angeles fighting for his life because he got this super E. coli that's resistant to everything from an ERCP scope that are very apparently difficult to clean. And they showed a little part on this particular scope, the ERCP scope, that had a little place where it was getting bacteria. And the people sterilizing the scopes weren't getting these bacteria off, and several people nationally have developed this resistant organism from the ERCPs that they had. There's several people nationwide, and they've traced it back to improperly clean, difficult to clean ERCP scopes.
Yeah.
That's what's caused it.
Because they're not cleaned by hand. They're putting a special machine. And so we were thinking that, you know, all those scopes go through the same thing. And used to a long time ago, before they had this procedure, they found out that we were giving patient diseases because of these small tracks in there. They were hard to clean and things. So we had to develop special machinery that would send the detergent through there with a pressure behind it that would make sure that everything was cleared out. Well, there's these little grooves and these little tracks and all this other kind of stuff, and that's basically where some of this is kind of materialized. Plus, there's been a shift away from nursing being in charge of this, and they're just having people downstairs who are central supply technicians doing this.
Yep.
And they don't have the nursing component in it anymore.
They don't really know what these scopes can do.
So, yeah, they're just told to clean them and to bag them and to ship them back out, and there's not that nursing component involved in them anymore. In fact, the University of Maryland has suffered from that recently themselves. Again, anytime that you have conscious sedation and you're going this direction and they have no gag reflex, you give them nothing until it returns, right? Okay. And of course, you assess for pain, bleeding, perforation, stuff like that. Anytime you have that tube going down, you can push it through the wall of anybody's esophagus or colon or anything like that. So you have to be extremely careful with that. That's it. Okay. The key to this whole thing is, or why we're going through this again, is because you're going to see more and more of these procedures coming to the bedside. Okay? So you need to know, at least have some kind of a tie, which is what this procedure is, so that you have some kind of an idea about what you as the nurse are going to be involved in doing. Okay? Sometimes this is quick. The doctor comes up with a cart, and they're like, "Nurse, I'm going to need your help." Oh, okay, well, I don't know what that means. I've never done this before. Well, hopefully maybe you'll have at least an idea of which end we're going to stick the scope in. Okay? And airway, 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 right? Okay, not quite so bad this direction. But up here, folks, you have to make sure that you're ready in case you have an airway issue. Okay? All righty. Any questions?
Plus, if you hear it in report, patient's going down for an ERCP, please ask.
Right.
Don't say, oh, they said all these acronyms, I don't know what they're talking about. And then you walk in your patient says, nurse, what am I going down? I'm going down for this test, what am I having?
Yeah, because they will, in front of everybody. And then all of a sudden you'll be like, oh, well, I guess I better go find out and come back.
That's how you learn these things. And there'll probably be new tests in the next year or two with new acronyms. So that's why you
Right.
have to keep
So that's the reason why we don't get rid of this particular thing, is because these tests are still being used, and some of them are coming to the bedside, and you need to know what to do if they come to your bedside, or in case you need to ship them off, what all that you need to make sure that they do. Don't forget to give them that glass, don't give them that glass of water, that kind of stuff to remind them. Okay?
Thank you.
Thank you. Bye.
Thank
See
you.
you next week.
Okay. One more cool thing. It's good tomorrow and one Friday. And this is on Blackboard, again, as I said.
Oh, yeah, it's under special procedures in the 2020 document. It's all right there. You can go
It
through it.
doesn't really test on test 3, but it will be test 4.